This episode is brought to you by... Oops, I've got a box of Cheez-It crackers staring at me and I just wanted that irresistible cheesy crunch. Sorry, that was a total snacksident. What was I supposed to be talking about? So salty, so crunchy, so cheesy. Whoops, lost my train of thought. I've heard of brain freeze, but brain cheese? I'll just have one more Cheez-It cracker and then I'll get back to it.
'Tis the season to cozy up with all your favorite holiday movies and shows.
You coming?
Where?
To the North Pole, of course!
Like A Very Jonas Christmas Movie and Home Alone on Disney+.
Did I burn down the joint? I don't think so.
Then snuggle up with The Polar Express and National Lampoon's Christmas Vacation with Hulu on Disney+.
I think we're all in for a very big Christmas treat.
This season, there's something for everyone with Hulu on Disney+. Bundle subscription required. Terms apply. Visit disneyplus.com/Hulu for details.
This is Dr. Ted O'Connell with the Med Prep to Go Step 2 podcast. Today we'll be reviewing 3 GI questions. Just a reminder that you can find these questions and many more at medprep2go.com. If you'd like to get involved in helping us to develop additional questions for this free question bank, please email me directly at ted.medprep2go@gmail.com. If you like what we're doing, please subscribe to this podcast, give us a review, and let your friends know what we're doing, as this helps with the podcast. All right, let's get started with the first question. A 42-year-old man is seeing his primary care physician after returning from Southeast Asia. The patient was visiting his parents in the Philippines for 2 weeks during the holidays. A couple of days after his return, he started having bowel movements multiple times per day that he describes as loose and watery, but without blood. He also endorses feeling nauseated with mild abdominal cramping. He remembers eating food from a street cart on multiple occasions during the trip. On physical examination, the abdomen is soft, non-tender, and non-distended, with no rebound or guarding. Bowel sounds are normal. He is afebrile with the following vital signs: blood pressure 130/80 millimeters of mercury, heart rate 80 beats per minute, respirations 14 per minute, oxygen saturation 98% on room air. The patient is provided information and tips to avoid dehydration. What additional management is most appropriate in this case? A, fidaxomicin. B, stool culture and sensitivity. C, levofloxacin. D, loperamide. E, abdominal radiographs. The correct answer is D, loperamide, which is also called Imodium. Traveler's diarrhea is a digestive tract disorder that commonly causes loose stools and abdominal cramps. It's caused by eating contaminated food or drinking contaminated water that has bacteria, viruses, or parasites. Most traveler's diarrhea is from bacteria. Food and water can be infected by not washing the hands after using the bathroom, storing food unsafely, handling and preparing food unsafely, or not cleaning surfaces and utensils appropriately. Traveler's diarrhea usually isn't serious in most people and self-resolves. Exercising caution when it comes to selecting food and drink while traveling can help to reduce the risk of developing traveler's diarrhea. However, it is recommended to take physician-approved medications when traveling to high-risk areas to use in case diarrhea persists or gets severe. Antimotility drugs such as loperamide and diphenoxylate with atropine, which is called Lomotil, can be used in patients with mild or moderate traveler's diarrhea and as an adjuvant therapy in patients treated with antibiotics. Antimotility drugs should be avoided in patients with dysentery, that is, with bloody stools. Bismuth subsalicylate, also called Pepto-Bismol, is another appropriate treatment for traveler's diarrhea because of its antimotility and antimicrobial effects. Widespread use of antibiotics for traveler's diarrhea has been associated with the acquisition of multi-drug resistant bacteria. Therefore, antimicrobials are recommended only for moderate or severe disease. Stool culture and abdominal imaging is not indicated in patients with mild traveler's diarrhea because it is typically a self-limited illness. This patient does not have a history or risk factors for C. diff infection, and therefore treatment is not indicated. Question 2. A 58-year-old man presents to his primary care physician complaining of 1 week of nausea, vomiting, diarrhea, and intermittent sharp epigastric abdominal pain. The patient has tried over-the-counter pain medications and antacids, which have not helped with the symptoms. He denies having any chest pain, palpitations, difficulty breathing, cough, fever, hematochezia, or melena. However, he does note mild generalized weakness, dizziness, and lightheadedness. The patient immigrated from Japan 20 years ago, and he has been operating his own restaurant handling seafood. The patient is a current smoker and drinks sake occasionally. He had a cholecystectomy 5 years ago and a partial gastrectomy for a gastric ulcer a month ago. He takes multivitamins, atorvastatin, and omeprazole. Physical examination reveals stable vital signs, a mildly distended abdomen, and hyperactive bowel sounds. Which of the following will be most beneficial for the patient? A. Fluid repletion and monitor for self-resolution. B. Start a low-fiber diet. C. Start a high-protein diet. D. Start a high-carbohydrate diet. E. Discontinue the statin. The correct answer is C. Start a high-protein diet. This patient's presentation is concerning for dumping syndrome status post-gastrectomy, a common complication. It can also occur after vagotomy, pyloroplasty, Roux-en-Y bypass, and esophagectomy. Accelerated gastric emptying into the small bowel without proper processing leads to GI symptoms such as nausea, vomiting, diarrhea, and abdominal pain, as well as vasomotor symptoms such as weakness, fatigue, and syncope, and autonomic reactivity symptoms such as palpitations, tremor, and irritability. A change in diet, such as more frequent meals, around 6 per day, that are high fiber and high protein in smaller portions, is one of the first steps in the management of dumping syndrome.
Meet the computer you can talk to. With Copilot on Windows, working, creating, and collaborating is as easy as talking. Got writer's block? Share your screen with Copilot Vision to help spark inspiration, and use Copilot Voice to have a conversation and brainstorm ideas. Or maybe you need some tech help. With Copilot Vision, Copilot sees what you see. Let Copilot talk you through step-by-step guidance so you can master new apps, games, and skills faster. Try now at windows.com/Copilot.
Question 3. A 45-year-old woman presents to the emergency department 5 hours after a sudden onset of severe, constant epigastric abdominal pain that radiates straight through to the back. Past medical history is significant for alcohol use disorder and hyperlipidemia. Family history includes hypertension in her father and breast cancer in her mother. She reports drinking 7 to 9 beers every day for the past 6 years and smoking 1 pack per day of cigarettes since age 20. She reports nausea and vomiting, but denies hematemesis, diarrhea, melena, chest pain, or shortness of breath. She was prescribed atorvastatin in the past, but reports not refilling her prescription in several months. Vital signs are temperature 38.3 degrees Celsius, which is 101.0 degrees Fahrenheit, pulse 108 beats per minute, respirations 20 per minute, and blood pressure 148/82 millimeters of mercury. Physical examination reveals a non-distended abdomen with upper abdominal tenderness to palpation and guarding, no organomegaly, a negative Murphy sign, and no skin abnormalities. Which of the following laboratory tests is most likely to confirm her diagnosis? A. Alkaline phosphatase. B. amylase, C, an aspartate transaminase to alanine transaminase, or AST to ALT ratio, D, high sensitivity troponin, or E, lipase. The correct answer is E, lipase. This patient has acute pancreatitis with a classic sudden onset of severe epigastric pain that radiates straight to the back. While the initial laboratory workup would include multiple tests, a lipase elevated 3 times over the upper limit of normal is 96% sensitive and 99% specific for a diagnosis of acute pancreatitis. Answer choice A, alkaline phosphatase, is incorrect. Alkaline phosphatase is useful in the evaluation of biliary obstruction. While included on the differential for this patient with epigastric abdominal pain, it is less likely with a negative Murphy sign and would not aid in confirmation of the suspected pancreatitis. Answer choice B, amylase, is incorrect. Amylase elevation to 3 times the upper limit of normal has a 95% sensitivity for pancreatitis, but only a 61% specificity. In conjunction with lipase, it is commonly used to confirm the diagnosis. However, isolated hyperamylasemia has several etiologies and on its own would not aid in the diagnosis of acute pancreatitis. Answer choice C, AST to ALT ratio, is incorrect. An AST to ALT ratio is useful in the evaluation of hepatitis. An AST to ALT ratio greater than 2:1 would suggest alcoholic hepatitis in this patient with alcohol use disorder. However, it is less likely given no signs of jaundice, hepatomegaly, or ascites. Answer choice D, high sensitivity troponin, is incorrect. Troponin is a marker of myocardial injury and therefore useful in the evaluation and treatment of myocardial infarction, or MI. While a significant proportion of MIs in women present atypically, this patient would likely receive an electrocardiogram to rule out a cardiovascular etiology of her pain. The key learning point for this question: a lipase elevation greater than or equal to 3 times the upper limit of normal is laboratory confirmation of acute pancreatitis. Okay, so that's it for this episode, but please do check out our other episodes, and a reminder that you can find these questions and many more at medprep2go.com. And if you like the contents of these questions, please check out the USMLE Step 2 Secrets podcast.